We'd like to start our thinking with a video that is a part of the on the Veterans Crisis Line website. Some of you may have seen it, but we thought it would be a good beginning, and then I'll proceed.
She just sat with me. That was all I really needed.
Coming, Mark?
We got back, and of course we went to different cities. One day he called me out of the blue, and it's comforting to know that I always can count on him to have my back.
Well, we hadn't talked for a while, and then she texted me, and we went for a walk.
She called me from time to time. I really didn't think I needed any help.
I was away from my family during the holidays, and a friend invited me to their house for dinner. It really meant a lot.
He knew I was having a rough week, so he asked me to go fishing with him.
My friend knew that I didn't want to go out, so she brought me dinner instead.
It took me from being really depressed to feeling like somebody cared. It gave me some hope. Just that one text.
Be there. Your call, your presence, your words, your support. Be there and help save a life.
So I'd like for each of you to take out your phones, and I'd like you to go to your contacts, and I'd like you to add a contact. And you can either put Be There, you can put Suicide Prevention Lifeline, Lifeline Prevention, whatever is going to be a good memory for you. And please record in it 1-800-273-8255. Press 1. And that's for veterans. The main line will get you there too. Yes, 1-800-273-8255. So that's the National Suicide Prevention Lifeline. What happens when you help someone use that number, or you use it yourself for information, resource, or help for support of another? Someone will answer that call in a matter of seconds. You'll hear a little ticker tape that goes, and that's the call going through. And then someone will answer, or you may hear a, "We will be with you in X seconds," and you'll hear another ticking, and someone will pick up, and you will have a person-answered call. And at that time, you can identify what it is that you have need for, and they can assist you. So it's a great privilege for me to be with you today. It's been a while since I've met with this group, and certainly have the opportunity to work with a number of you across the state, and new faces here today as well. Let me make sure that I have the right position. I do. All right. So today we come with a lot of different perspectives. Each of you, in introducing yourself, identified those perspectives. And there are many of us who are touched by suicide. There are many of us for whom the ripple effect of suicide has touched us. And it is a part of the work I do, and typically I would be presenting with someone with lived experience, to take a moment and honor that perspective. So if you will, please. What we know about suicide is it's complex. This isn't new to any of us in the room, but there is no one cause. There's a combination of factors, and they accumulate over time. There's sometimes a precipitating event, but not always. There are population groups that are higher at risk than others. Some of you work with those high-risk populations. Some of you may experience those challenges and risk factors. And there are many protective factors that can balance out the risks. And we know that effective prevention is a set of strategies, not a single one for one community, for one individual, but a set of strategies that, sustained over time, implemented with an effective fidelity, can have long sustaining impact. And that's for many of us our goal in our room today. And we've already touched on those who have different perspectives and how it is that we come to have a passion, an interest, a profession, a family member, community member for whom we are concerned or for ourselves. Oh, wrong way. So we understand that prevention is possible. And for many years, prevention was not deemed possible. It's population-based, and everyone has a role in suicide prevention and safe messaging. Intervention requires many strategies. First, to strengthen the protective factors and to understand what those are, reduce the risks, safety planning, which many of us are a part of, and the reduction of harm. Treatment. Treatment is one of our larger challenges across our sectors, and I hope that we'll have some open dialogue about that today. It's informed by what works, it reduces risks, and it sees the risk factors as alerts or attempts in our safety planning and our treatment planning. And postvention and recovery are prevention. Schneiderman in 1992, who really pushed the national movement, equates postvention, good follow-up, immediate follow-up, and sustained follow-up is prevention. So where are we in North Carolina? We have been fortunate to be one of the leading states to implement suicide prevention, to actually develop and draft a suicide prevention plan statewide. Some of you were participants early on and think agents with us, and some of you have come along with us in this journey. The North Carolina State Plan was put together with a great deal, a number of stakeholders, through the leadership of the Department of Health and Human Services with Division of Mental Health and Public Health as co-leaders. And it very much aligns with the National Strategic Plan on Suicide Prevention that was produced by the Surgeon General's Office and SAMHSA in 2012. And I know that if you look at the two, you can see it mirrors. It's a composition, it's a roadmap. It identifies priorities, it identifies strategies, and populations in which there can be effective work done. In our North Carolina plan, it also identifies communities and areas in which practices were begun or where coalitions were beginning to think about prevention at the time. And that has progressed. 2012, the North Carolina Institute of Medicine helped the Division of Mental Health put together a targeted suicide prevention plan for what we consider our high-risk population in North Carolina. Those who already have known identified treatment needs and rehabilitation and habilitation needs, and for those family members. So looking at some good clinical practice in it, you'll find it in the appendix, which I submit to you, is a great resource for best practices across populations, very easy to use. You'll find a couple of the appendixes very useful in both of these documents, and I'd be happy to point those to you later. So these plans have in common creating a supportive, safe environment that promote the health and empowered individuals among us, enhancing clinical and community preventive services along the continua, promoting availability of timely treatment and support services, and improving our suicide prevention surveillance, understanding what the numbers are, understanding what our death certificates say and don't say, understanding what our medical records, the violent death reporting system, and the hospital system actually gathers and collects to help us better understand what our needs are and where there are some pressure points where we can have effect. One of the very first things we did in 2012 was to make certain that we had a suicide prevention lifeline, which that number, by the way, is 1-8. Oh, you can be louder than that.
1-800-273-TALK.
Yes, or 8255. That's right. So in 2012, it was one of the first things that we did was to make certain that the Suicide Prevention Lifeline was available in all 100 counties with a person response. And since then, we've had to staff it up twice. I can tell you that we began with a call volume during 2012 of less than 2,000 calls. That grew incrementally to 5,000 3 years ago, and we are now at over 8,000 a month. And this, the last 2 weeks alone, we have averaged over 2,000 calls a week. So if you think about the number of calls, and you think about those who are calling this line, the North Carolina call center is located in Greenville, and it is 24/7, 365. So if you call the national number anywhere, you will be put in touch with the North Carolina line if your cell phone or if your phone itself has any connection to North Carolina. We also do a rollover backup for a couple of other states as well. So you might ask, so how many vets call? And how many women? How many men? What's this look like? So it's about even in terms of men and women who call the Lifeline, and for veterans, it's right around 9% on an average. Now, in some communities where we would expect it to be higher, it is, and that percentage of callers from vets is higher. And I know probably Gary's going to speak a little bit about this, but I don't want to be remiss in mentioning that the Veterans Crisis Line, if you press 1, does go to the VA now fully manned, not one of the backup call centers, which North Carolina was one of. And there's a fully manned person center in Atlanta, and there's one in Canandaigua, New York, the original, and a new one that will be established in Kansas. And I believe the one in Atlanta hired 500 folks to staff that particular center recently. So in North Carolina, the other piece that we've paid attention to is the crisis service array and the continua. And so you can see that early response, identifying initial need, early identification, solid screening, consistent screening, and then attaching to mobile crisis if needed, or other 23, 24-hour service supports, specific treatment if one is known to treatment, some additional wellness and recovery and action planning and other safety planning, looking at traditional and non-traditional supports, and more intensive services. So mental health first aid, you saw that in the continuum. That's a universal way in which we can do some first aid for our minds. In the same way that we do CPR for our hearts, mental health first aid is for our minds and our bodies, our wellness. So how many of you have heard about mental health first aid? How many of you have participated in training? Good. And how many of you might be instructors? Wonderful. We'd like to see that increase over time, and so we can look forward to that. The Division of Mental Health sets aside $500,000 of Community Mental Health Services Block Grant, which is a federal fund, specifically to make certain that mental health first aid instructors are across the state, available to you, and at minimal to low cost or no cost. And we particularly want to see our communities at large trained, all ages. So, what have we been doing? What is in place? Crisis intervention teams. So, crisis intervention training with law enforcement. Many of you heard of this. So, this is a training that helps us to help law enforcement understand signs and symptoms, understand stigma, and help to de-escalate so that there's a diversion not to the justice system, but to the appropriate treatment, whether it be substance use or mental health treatment. And it's very effective. So, how does that apply to you? So if you find that you need to call 911 or engage emergency services, you can call 911 and you can ask that dispatcher for a CIT-trained officer to come. And they should know what that is and connect you. So also we have our higher education, our community campuses, our community colleges, where many of us are working to engage employment among our vets and military members and our Guard. Active Minds, Cognito, Assist, which we'll talk about a little bit later, some gatekeeper training that helps identify and work with individuals in suicide prevention. So quickly to understand signs and symptoms, to ask the question, be willing to ask the question, are you planning to hurt yourself? Do you plan to kill yourself? Let's talk about that and let's get some help. How did you get there? Psychological first aid is different than mental health first aid, but helps in terms of after response, in particular, when there's been an event that shakes the community. So that could be disasters, natural disasters. It could be serious motor vehicle crashes, other sorts of things that occur in the community where there's significant devastation, fires. Suicide survivor support groups. So these are the place in which families and those who are touched by suicide can get support, can tell their story, but also constructively figure out how it is that they live with the grief and the loss and the unanswered questions, which, by the way, there's often few. And we have a growing number of those that we're partnering with the American Foundation for Suicide programs and also with faith communities in a big way. Counseling on access to lethal means, that's something that our VA partners are doing on safety planning around lethal means. And we can talk about that further. Trauma-informed systems of care and treatment, understanding what adverse childhood experiences, how they impact each of us, and how our resilience plays a part in being able to move forward and take the next step. But also thinking about the cumulative rocks, if you think about the cumulative rocks, the things that build up and leading to to a suicide attempt or suicidal ideation. Oftentimes, it's those unresolved pieces of trauma. And paying attention to that more and more, and there's more and more evidence to do so. And then, of course, we've talked a little bit about transition coordinating and rapid response from our medical facilities and urgent care before and after. So we've recently had the opportunity, and I'm thrilled to say that we've been doing some awareness education with ROTC and on our campuses. So 5:45 a.m. Yes, we are there. And I can say that those youth are far more awake than the adults coming to speak to them. Teen summits, our faith and our tribal communities have been very deliberately paying attention to suicide prevention and the risks that our teens and our youth are experiencing. And as we parents, grandparents, are interfacing with our children, and you may be important to a child in your community or your neighborhood. So there's a good outreach there. Media best practices and safe messaging is very key, and there are some very excellent strategies for this. And we each have the opportunity and the role to engage in good public messaging that's safe messaging, not of an epidemic alert, because that tends to tell us that there's a crisis with no answer. And remember, we started out thinking that prevention is possible, and it is. So we want to be certain that we're doing some safe messaging and not creating secondary trauma. Some effective treatment practices, such as CAMS, is something that helps to target not the depression, not the illness itself, but the actual idea of suicide, and working through that with an individual. Some of these things we've already spoken about, but there are community partners in our state including our local management entities and managed care organizations, among which there are 7 in our state from the division, our Division of Public Health, our nurses that have been trained in mental health first aid in those centers, our rural health centers are becoming more trained, our CCNC and other clinics where they may touch individuals who are Medicaid eligible and looking at their depression algorithms as an example. And then, of course, the National Alliance on Mental Illness, on which there are a number of affiliates, I think over 22 in our state and multiple county, and their programs are very effective and targeted. We've talked a good bit about these things, highlighting again the opportunity that we have across our state. So, we have some challenges. One is, and I'll just go back a minute, I mentioned trauma, and I also, I guess I didn't mention toolkits yet, so let's talk about toolkits. There are a lot of toolkits. There are more coming out. The VA just came out with a toolkit. If you haven't seen it, take a look. It's very practical, reasonable for us to pay attention to, and I believe that we've left a link for you in some of the material that Lee sent. If not, we'll make certain that you have it. SAMHSA, the Substance Abuse Mental Health Service Administration, has some excellent toolkits on older populations, on populations in particular settings, and here in primary care. Now, it says it's a rural health primary care toolkit, but I can tell you right now that Canada and this particular toolkit are excellent in terms of some of the guides that they can give us in terms of how we coordinate and interface our health and our behavioral health systems. So, another challenge that we have is zero suicide. I think maybe some of you have heard about zero suicide. Maybe? No? Okay. Well, it's a challenge. And the National Strategic Suicide Plan and our VAs are challenged, as our public sector mental health and health systems are challenged, with touching individual lives and understanding that when we touch an individual life in care, that there should not be a suicide event that occurs with this individual or a suicide death. And so how is it that we set up systems to do that? So, Air Force has learned how to do that. They did an excellent job of setting an example and setting a mark of how to do that well, universally, routinely, with a common understanding. And Michigan, Detroit, Ford also did the same thing. Our next challenge is doing something I spoke about earlier, connecting the trauma that we experience as a child, that we may experience as an adult, the trauma that we experience in battle, the trauma and the secondary trauma that is experienced in the very idea of military training, of your job. And how do we address that? So this just is a snippet to whet your appetite. If you want more information, the CDC website has great information. We have some additional information, but this gives you an idea that if you are more than 3 or 4 events of ACEs, of adverse experiences that might be above, you have a higher index of having a health problem or dying earlier. And we know that that's true with our individuals with behavioral health needs. So in closing, we started in talking about the fact that we have a great partnership ahead, and we have great partners working together currently. And these are just a few, and you're among them. So this gives just a quick overview and the beginning for more dialogue. Thank you.